Hi there, and welcome to my presentation on the early isolation screening tool, which will be used for emergency department infection reduction. The early isolation screening tool is an important resource to minimize healthcare-associated infections and healthcare worker exposures within hospitals. The purpose of this project was to improve compliance with the early isolation screening tool. Unfortunately, due to COVID-19, we were unable to complete this project. However, we still outline our anticipated processes, results, and supportive literature. This research displays the significant role that early isolation and subsequent initiation of transmission-based precautions plays in reducing the spread of infection. The emergency department is one of the most commonly visited healthcare locations, with approximately 130 million visits annually. The ED is often the first point of contact for patients who will be admitted to the hospital, and it provides ample opportunity for pathogen transmission. This is due to close physical proximity of patients with varying illnesses, high frequency of staff-patient contact, and plenty of invasive procedures being performed. The EDs play a significant role in identification, triage, and application of proven infection prevention and control measures to reduce the risk of transmission of communicable disease within the facility. Best practice is to implement transmission-based precautions as early as possible, especially for patients with known or suspected epidemiologically important pathogens. And then recent outbreaks and epidemics such as the respiratory syndrome coronavirus in 2004, novel influenza A in 2009, and the current coronavirus, COVID-19, in 2019 highlight the need to consider ED preparedness for early isolation and implementation of transmission-based precautions. So, the early isolation screening. At our acute care facilities, this is the first tool utilized to initiate transmission-based precautions in the triage/admission process. It's a signs and symptoms-based screening that uses proven algorithms and appropriately identifies patients with potentially transmissible infectious disease. And it also distinguishes which type of transmission-based precautions would be warranted based upon the current signs and symptoms. So here is this figure. It displays what we see within our electronic medical record. And you can see what type of transmission-based precaution would be applicable for certain symptoms. So the current problem, which was originally written in February of 2020, was that our hospital was only compliant with this screening tool approximately 70 to 75% of the time. And this percentage encompasses the number of early isolation screens performed per number of triage encounters at our emergency department. Our goal should be to have this at greater than or equal to 90%, and that the actual ordering and implementation of the transmission-based precautions is equal to that. We must first incorporate evidence-based articles to display that screening and isolation of patients is an effective way to prevent the transmission of infection. We need to involve our stakeholders. So the current rate of the early isolation screening compliance and ordering of transmission-based precautions should be provided to the Chief Executive Officer, the Chief Nursing Officer, and the lead ED physician. And our concerns about the associated risk of an outbreak of healthcare-associated infections and the safety of our patients and healthcare workers should be highlighted when discussing it with these stakeholders. Our primary goal would be to directly educate managers who would then be responsible for training the ED staff, and a survey should be sent to the ED staff to help us narrow our focus of what educational material to provide. And then we can send out monthly updates regarding compliance of this tool and include other supportive documentation for appropriate infection prevention education. A secondary proposition that I had come up with is, although we don't have current data to display the compliance, if we notice that it still is subpar after doing the education, we could work with the informatics team to implement a hard stop within our EMR, requiring RNs to order transmission-based precautions prior to being able to leave the encounter or move on within the encounter. So moving on to our literature review here. On the right, we kind of have a little synopsis of each of the studies that I have included within this. Well, not all of them are included within this PowerPoint, but they were used during the entirety of my project. So some control measures such as screening questions via triage, transmission-based precautions, and improved hygiene are important to prevent the spread of infection. The use of electronic medical records and electronic reminders within the EMR has been shown to improve compliance with infection control practices, such as the transmission-based precautions. And then syndromic algorithms have been shown to be an effective mechanism to determine if transmission-based precautions are warranted. Specifically, the sensitivity and specificity of respiratory algorithms is approximately 82%. For cutaneous syndromes, the sensitivity and specificity are approximately 78 and 95%. And the sensitivity and specificity of gastrointestinal syndromes were approximately 79 and 82%, which supports the notion that early isolation screening is accurate. And here we go. So you can kind of see the literature review is continued here on the left. The only one that I really want to point out here is on the bottom, which is that early isolation can help control outbreaks of MDROs such as extended spectrum beta lactamases and carbapenem-resistant Enterobacteriaceae. And then this figure on the right here objectively displays how early isolation and transmission-based precautions could have improved healthcare worker safety if compliance were improved prior to the COVID outbreak. Specifically for us, 25% of our documented exposures resulted in COVID-positive caregivers. Furthermore, the majority of exposure sources were patients, and almost all of these exposures occurred when a healthcare worker provided care to a patient before COVID was suspected. So our exposure source was the patient, 61.5% of the time. 31% of the time it was an unidentified source, and 8% of the time it was another caregiver. The change theory that I've incorporated is Prochaska and DiClementi's theoretical model of change. And the main reason I selected this method is because it revolves around decision making of an individual. And that's kind of what we're focused on here with our triage RNs and our ED staff. Furthermore, it assumes that people do not change behaviors quickly and that a change in behavior occurs continuously through a cyclical process. This description stuck out to me because our goal is to have continuous education of our caregivers and really describe the importance of early isolation. And this model allows us to assess each caregiver individually and determine which stage they are at and to make changes based upon their needs. And so the different stages are pre-contemplation, contemplation, preparation, action, maintenance, and termination. And then the 10 processes of change, which can also assist in identifying what stage an individual is currently in, are consciousness raising, dramatic relief, self-reevaluation, environmental reevaluation, social liberation, self-liberation, helping relationships, counter-conditioning, reinforcement management, and stimulus control. So team members and roles. So our department, which includes infection preventionists and infectious disease physicians, play the largest role in providing adequate evidence to gain approval of our hospital leadership. And that would include the CEO, CNO, and other leaders involved in quality and risk management from a regional perspective. And without their approval, I mean, we can't incorporate any of these proposed changes. So the informatics team can help determine what capabilities we can improve upon within our electronic medical record if we wanted to implement something such as a hard stop. And then our ED staff is responsible for implementing these proposed changes, and ultimately we want to gain their trust to ensure compliance and a smooth incorporation of our proposed changes. So some barriers. The initial barriers that I was anticipating were cultural resistance of the CEO, CNO, and lead ED physician and/or RNs. And I also expected triage RNs to feel discomfort associated with ordering empiric transmission-based precautions without a clinical diagnosis. And then some of the current barriers. Instead of considering COVID-19 a barrier, which may be like the most obvious barrier right now, I kind of like to think of it as a doorway. Before COVID, this door was shut, and now that COVID has happened, this door is wide open, and infection preventionist guidance is highly valued, especially within our hospital leadership, which provides us with a unique opportunity to do a quality improvement project such as this. Um, and we can always encourage basic infection prevention and control, such as hand hygiene, standard precautions, and transmission-based precautions. So to conclude, unfortunately, I lacked bandwidth to complete my project. However, my aim was to increase early isolation screening compliance and subsequent initiation of transmission-based precautions. And we anticipate that the heightened awareness of these tools due to COVID-19 has resulted in a substantial increase in compliance. And here are the references included. And that is it. Thank you for taking the time to watch my presentation.